Record. Good evening and good morning to Australia. Thank you for joining us with Coffee with the Kingpins. I'm very, very excited to have tonight with me Dr. Georgia Hale, and we are going to go into it. So, hi, Georgia. Nice to see you. I know you, it's morning for you, but it's evening for me um, due to huge time differences. But welcome, welcome. I'm very excited about what you have to share with us tonight. Tell us. So, give the viewers a little background, where you're from, where you were born, how you were raised, and what brought you to become a doctor. And go for it.
But I was there. We've known each other for some time.
Yes, we have.
We have like-minded sort of things, don't we, between us?
We do.
Yeah, which I
Definitely.
don't share with many medical doctors, mind you.
Oh, okay. We won't go into
No,
that. It's just that um, very softly, we are both into spirituality, and we'll leave it at that.
yeah. So I studied medicine for 6 years. You go from 12 years of school, where we are, so pre and high school, and then you go straight to university, or it used to be, no pre-med, and 6 years of undergrad. Then I graduated, and then I wasn't sure what to do. Did a bit of emergency medicine. My father's a cardiologist. I sort of thought I was more specialization, so I did go into specialty training. Got through that in 4 years, and then you have to choose your specialty.
Right.
So we do a lot of specialty training in the hospital setting, which was the biggest time that I saw sick patients, one after the other, in night and day in the hospital system. It's all hospital stuff when you do medical specialization. And then I decided I didn't want to be woken up in the middle of the night, which I would be if I was cardiology or anything like that.
Right.
I guess endocrinology, you can answer anything at the end of the phone and put the phone down and go back to sleep. So, and my dad actually happened to be the cardiologist for the infectious diseases hospital in Victoria, Fairfield Hospital. And I did a little bit of student work there. And I thought I'd do infectious diseases because it was a sort of a new specialty. Clinical microbiology was coming up, but infectious diseases, where in the hospital setting, you see anyone with a fever, anyone with a opportunistic infection. They are the busiest infectious physicians in the hospital, and so busy that once I got through in another 4 years of training, so it's 8 years total after my graduate degree. You don't do that. You can do board training in the US, but we have to do this 4 years pre and then 4 years of your specialty
In Australia.
after your 6 years. After your 6 years, so you get so sick of the hospital anyway. I Because of the hours and because I wanted to go to the Olympics, I was still running. Remember, I was running a lot when I was younger and wanted to get to a 4x100 relay track. I just sort of thought, no, I don't want to be a staff specialist in a hospital and work from, you know, 7 till 8 at night, 7 a.m. to 8 at night, and you don't get overtime. It's a big job.
Right.
It takes your life away. And my dad had a wife, and he had her have the children, and you just can't do that as a lady doctor. So I chose infectious diseases, and then I quickly went into sort of private practice. Now, being in private practice, you get a bit of more kind of like open to doing other things, and I went in to do some functional medicine. So that's really how the body works and explains more about why people have symptoms prior to disease diagnosis. So I was really interested in that because I got to work how the gut works. That wasn't in my specialty training, still isn't for gut specialists.
Hmm.
And that was really important. Of course, microbiome issues are really coming up with popularity, but just the mechanics of a working bowel is just like fascinating. It's just like you made a huge difference to me working through abdominal pain and other abdominal issues that wouldn't be addressed by any specialist, any other specialist. And then once I did the functional medicine training, uh, actually I did the PhD. So I was open to other things, general medicine, infectious disease, and I did a PhD in midlife women's hormones. And this, I did this because while training for the Olympics over in Los Angeles, I met up with the right people, and I just got so interested in the workings of the hormones prior to and during the transition to menopause. Menopause is when your periods have stopped and your ovaries and kind of are starting to really wind down in a big way that they don't produce a lot of hormone.
Right.
So I did this research there and then came back to Sydney and did my whole PhD, which is what my book is really about.
Hmm.
Then I did the functional medicine, which allowed me to much better explain women's symptoms
Right.
prior to having any diagnosis of like menopause or anything else. So I could then work on symptoms and how to help women take charge of their own symptoms, and why I've called it Learn to Take Charge of Your Health using scientific facts and your own intuition, because you have to sort of tune in to your own symptoms in order to go, I need to see someone about this.
Well, the reason that I was very interested to interview you was number one, you published your book, but more importantly, because there isn't enough research and information about women's diseases, like there's not enough out there. And for women, they have to kind of like run around trying to find different venues, and it's really hard to come by. So it's really interesting, and I would like you to share a little more in depth about why you chose that. And I mean, it's a great service that you're doing.
Now, there is a lot of research on menopause because menopause, oh, hello. Oh, I've got a little cat, Yodi.
Cute, yeah.
Gee, have a look at the camera. Good boy. He likes sitting on our shoulders. We think he was a parrot in his past life. Anyway, so good boy. Yes, you are. Um, so there is a lot of research in menopause and diseases, etc., because what the medical profession likes to do is sort of categorize and diagnose. So you had a diagnosis, great. Now you got all the drugs, right? What are you doing? And so there is quite a bit of research on menopause. Once your ovaries have stopped producing all the cyclical hormones, and then you don't get the menstrual period, uh, a consequence of that, whether you've got a uterus or not, your ovary will produce the cyclical hormones. And once it's stopped doing that, it's in a menopausal state. Wow, we have a diagnosis, and then we have all the drugs and all the antidepressants that go with it. So it's actually a lot of work done on the bone, some of the mood things, the hot flushes. Now we're getting into cardiovascular disease. It's actually a fairly well-studied area. But what wasn't studied is what women are going through prior to the menopause.
Well, I mean,
And
the
it's very
reason I
complicated.
said, yeah, the reason that I said there isn't that much because I personally had an issue
There's
with
not much awareness of the study
right,
by the health
fibroid,
profession.
yeah, fibroids, and I, I,
Fibroids, exactly.
I was at a loss because I couldn't find information. I didn't want to get the surgery. So, yeah, it was a very arduous and actually a difficult experience at the time. But yeah,
Which you would choose would be one of the most difficult things because it's it has to be really it is you can't stop the growth of them unless you stop your estrogen cycling, which is really tough. I mean, then you kind of got to either take the oral contraceptive pill or some way of kind of reducing the estrogen. or you and then wait till menopause, or you try various techniques to which is surgery. Sometimes you can remove a fibroid, or sometimes you can inject them, which is very painful because if you inject them with something that's going to cause death of the tissue, it's
Right.
painful. I've had several patients who've gone through that. It's hardly worth it. So
Well,
non-surgical approach of
they were,
fibroids is
yeah,
difficult.
they told
You
me
picked the
that,
hardest one.
um, m- certain measures that I found out later on, it eats away at the bone. So I didn't go through that. And I actually was rushed to have surgery in a week because I found a lady, because, all the doctors that I went to were men, and they were like all saying, go take everything out. And I'm like, why? Anyway, long story short, she had checked my MRI, and because it was sitting in a watery sac, she said that usually it's cancerous. But later on, after the surgery, what I found was that if they did a blood panel where they would look at my hormones, then they could have actually balanced it because it was due to very high levels of estrogen. Anyway, so I did have the surgery. It was 6.5 hours. They had to completely open me up because they thought it was cancerous. Thank God it wasn't. But yeah, and plus, I had my hemoglobin was down to 5, so I had to get blood transfusion. Then I had an allergic reaction to the blood, and then they told me that they had to transfuse me, while I was on in surgery. Anyway, it was very dramatic, but I felt uh, pretty. I really felt myself that I didn't have cancer, so I wasn't afraid or anything. But thank God, later on, it was all fine. But what I'm saying is what I had to go through I was trying to find information about what it entails and why, and I couldn't find anything until I found a group of women.
Yeah. Well, actually, the balancing effect of progesterone doesn't work on fibroids. It
Mm.
works on the endometrium, but it doesn't work on those fibroids. So it hasn't been successful. The balancing effect of progesterone. That's number one. But you could have, because of the high estrogen, in my book, I talk a lot about encouraging your body to uh, detox from the estrogen. You
Mhm.
wouldn't have thought we need detox from our own chemicals, but we do. And estrogen is a steroid hormone, and all the steroid hormones have to go through this complex process involving the liver and the bowel. So if your liver is a bit slow and your bowel is particularly slow, bile flow is slow, they're the things that can help block up the estrogen flow through the body and make fibroids worse. So
Mhm.
that's the kind of balance that I talk about in the book.
Right.
With progesterone, it doesn't seem to help stop the growth. It doesn't have the progesterone receptor like the endometrium does. So it's one of the hardest. But you certainly need people who know how to help reduce estrogen, which other than with pharmacological methods.
Right.
Because absolutely, you're concerned about the bone because of that. It's a real. Mm.
Yeah. Interesting.
So yeah, I mean the research is there, but a lot of people aren't aware of it, and we still find family doctors that really have such a simplistic approach. And I think it's encouraged by the pharmaceutical industry. The simplistic approach of, oh, yes, you treat flushes and you give this and
Right.
don't ask any more questions because they've got so much other stuff to do. There's no real personalized medicine
These are all
in the
band-aids.
mainstream.
Yeah, but not getting
That's
to
right.
the cause of the issue. Yeah.
Yeah, so that's why I like functional medicine and teaching it to women and patients because it gives them control and a choice. If you don't know anything about what is suggested, you start off with fear and you think, oh, I better follow instructions. Whereas if you're informed and you can say, well, no, I might try something else first or do this or do that, And that's why I like to have women be in the know about their symptoms because they can then say to a GP or a family doctor or a healthcare provider, no, but I've got these symptoms, and they will get a clear message from their provider who'll say, oh, they don't mean anything. Don't worry about those. It's like, oh, I need to see someone else, or I need to look further into what I've got because they're trying to sort of slot you into a diagnosis to give you their therapeutic rather than listen to what symptoms you have and what they might mean and how you can reduce them.
So when did you publish your book and where is it available? I actually have two clients of mine who are in the medical field specifically. They're actually uh, one is a naturopath.
Yeah.
Anyway, they were. I mentioned your book, and they were both interested and wanted to get it.
It's on Amazon and you can get an ebook or a beautiful color book. Uh, I really enjoy colors, for making things a bit more interesting. I've got some illustrations. I've got some pictures of the farm where I live.
Yeah.
Um, I mean, it's a good quality book. I wanted to make it that way because I want to have it be a reference book for people. It's just not a one read and then chuck because people will go through. If you're 35 and over, if you've reached menopause, there'll be certain sections that are for you. But if you're 35 and you're starting to go through the transition, you'll actually use it for the whole time
So
because
let me ask you a question. Sorry, go ahead, finish your sentence.
your transition to menopause is divided into phases, and that's the scientific approach. So I've simplified it into zone 1, 2, 3, 4. So you can pick where you are in terms of that transition to menopause and then use the book according to that. It is available on Amazon and any other bookshops, and we're getting I think it's a 20% off for the Christmas period.
Oh, nice, 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 nice. So one question that I had, have you noticed that women are becoming menopausal or premenopausal much earlier than maybe 25 years ago?
Haven't noticed yet.
No? Okay.
Kind of expecting it, but not yet.
I mean, I hear,
Um,
you know, girls 25 being premenopausal. That's like shocking. And I wondered if
going to
you
be a lot of
do
there's going to be probably a lot of contribution to that. Yeah. There's
environmental stuff. Yeah, exactly. Yeah.
toxins and certain injections that seem to target ovarian tissue, and the consequences of injections, including increase in autoimmune disease, because primary ovarian failure is basically an autoimmune disease, and that results in early menopause, which if you don't recognize it and get on hormone treatment, it's catastrophic, the
What kind of
consequences.
injections may cause that, would you say?
I'm talking about the recent injections
Oh, I
starting in
see. Right,
2021.
right, 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 right.
Mm. Yeah,
Wow.
a lot of unknown and yet to be studied
Yeah.
side effects, etc., etc. Um, Other than that, autoimmunity, like I have a member of my family had autoimmunity affecting the ovaries. So yeah, but it is environmental triggers really.
Would you say, I mean, in the old days, well, I mean, old days, but I mean, before, women would have children at an earlier age. Do you feel that that has something to do with it as well? Like,
No,
no?
I don't think the age of when you first have a child affects menopause. Not many things do. It's pretty robust. It's quite strange how it's changed. It hasn't changed from sort of average age of 51 for years, but I'm waiting for that change because of the increased toxicity, the exposures, the increased autoimmunity we're seeing. Um,
Yeah, I mean, I'm not
you
a
know,
doctor, but I deal with a lot of women because of what I do as an esthetician, and the things that I hear are just mind-boggling. Mind,
yeah, because there were menstrual changes with that recent mass intervention. There are a lot of menstrual changes, and I looked into kind of the possibilities of how it could be doing it, and the lipid nanoparticle that it was delivered in had quite a propensity to go to several organs, including testes and ovaries. So it was like setting up an inflammatory response, could have a lot of damaging effects on the usual ovarian follicle maturation process and
I mean,
survival process.
I've heard some studies regarding men that it's actually caused them to become incapable of becoming fathers, and also a major cause of impotency. So,
Yeah, it's multifactorial, really, in that regard. So yeah, so I mean, back to the research that's really missing was not once you reach menopause, it's actually throughout the transition. And Nina Kozloff, who created Women Living Better website, she has run her own questionnaire studies, which have been really informative. And she's actually published them in peer-reviewed menopause journal. And she's really organized a sort of a group of email group, which I'm part of, with all the most experienced researchers in women's health. And they too are like, oh, well, we didn't think we had to look at the midlife to perimenopause transition, because they
right.
just sort of thought, oh, well, it doesn't matter anyway, because if you just have your flushes, then you just start estrogen. So what
And
I'm finding is that for 35 and over of certain symptoms, tune into your symptoms. And, we don't have the robust data. My data did suggest it, but through that 35 and to 45 age group, you lose a lot of progesterone in
mhm,
your luteal phase.
right,
Not the basal, but your luteal phase seems to come down. It's hard to do the studies that show us exactly, because remember, you've got it over, say, 15 days, the rise in progesterone through the second half of your cycle, and you've got to catch that every day in order to not get an average and miss the peak, and it's just complicated.
mhm,
But what I'm finding is, certainly in my practice, that supporting women with either a cream, and I know about the problems because it's not pharmaceutical driven, it's more
right,
compounders,
yeah,
um, or an oral progesterone, but I prefer the cream when they're in their midlife. And it has enormous effects on the brain, irritability, premenstrual tension, and premenstrual symptoms, really consistently. Now, that study should be done properly. There have been some studies on, I think, the cream, but they stopped them altogether because the cream didn't change blood levels. But we know that creams and other transdermal ways of getting the drugs, they don't tend to go into the blood as much as they do the tissue. And the tissue is actually where it works.
right. Would you say that,
So,
I mean, every woman is an individual being by itself? Because I mean, there's some women who don't suffer from hot flashes. So wouldn't you say that, I mean, of course, probably there's a blood test involved before you recommend any sort of, yeah, yeah,
yeah. So a lot of women are keen to have hormone therapy for all sorts of reasons. Bone, they may see it in their family history, their osteoporosis.
right,
They may feel strongly that they want it for their brain or anything else. Very difficult to confirm this on studies. Can you imagine the length of the studies? Can you imagine the confounding factors? Can you imagine one group of statisticians will have an outcome, another group of statisticians with a set of instructions will have another outcome?
right,
This is rife in the research community, is that you can take a set of data which is going, a longitudinal set of data, millions of people, and you say, oh, we've got a really big study. But the problem is, depending on how you look at it and how you know, control for confounding factors, you're going to have a different outcome.
right,
It's really a minefield. So they can say stuff like, oh, it doesn't help skin, or it doesn't help the brain. There's been several studies on looking back at who used hormone therapy and who didn't. And they've actually found, oh yeah, hormone therapy users don't, seem to get dementia earlier. Well, that doesn't make physiological sense when
Right.
hormones are trophic hormones. And with the loss of trophic hormones, we know there is a loss of like brain tissue. So a lot of these studies are very difficult to do. So when patients do come along and say, look, I really want hormone therapy, they don't have, for me, they don't have to have um, uh, hot flushes, but they have to be clear of contraindications, or if they do have contraindications, they've got to basically agree to on an email to
Right.
go along with the risk factors.
Right.
And again, it doesn't look like the original fear campaign of the breast cancer is really bearing out either. So it's that's been the biggest scare campaign, really. And it does seem that the addition of progestins, even progesterone, may kind of muddy the waters a bit in terms of risk factors. But definitely for bone, we know it helps. So a lot of people want it for the bone, despite having no hot flushes. So there are reasons that I would consider hormone therapy, and even before menopause, depending on their symptoms. But it's usually progesterone before menopause that I use, and I tend to use the cream, or if sleep is a major issue, I'll add the oral version, the tablets, progesterone, and that's the human equivalent hormone. I really do try to avoid the synthetic progestins because of all the other side effects.
Yeah, it's interesting because, as I said, I deal with a lot of women, and I see women in their mid 50s, especially, that are not on hormone therapy, and they went into menopause, in early 40s. And the reason that they don't do anything, and I can see a huge difference in their skin, the texture, the
Yeah,
fiber, the elasticity. And I asked them, so are you doing anything? And they're like, no, you hear so much about, how it causes breast cancer and stuff. So again, I don't know if it's not, the research is not available, but these are belief systems of, I don't know, 40 years ago when, there were more synthetic stuff, hormones that were used. So,
there's two things involved. It is to do with the complexity of research,
right.
the logistic difficulty of research, but the second thing is pharmaceutical driven kind of like favor
Yeah.
and what they want, and protecting themselves. The WHI, which was stopped prematurely because of the increased risk in the progestin arm and stroke, it was actually stopped because of the stroke, but then post analysis of the study suggested that there was a slight increase in breast cancer in those who were taking the oral equine tablets and the oral medroxyprogesterone, which is a synthetic progestin. And really, it certainly wasn't in the estrogen only arm, and it was a small increase. And we've now seen that it just doesn't seem to be borne out in other studies. So it's actually not a lack of study, it's a confusion. It's different experts having different opinions about what the data said,
Uh-huh.
even the data alone. So the studies on cardiovascular medicine, on dementia ones are all over the place, like a pig's breakfast. They're very good studies, but it's the interpretation and the people interpreting them, the statistics. It's a nightmare. And then you'll write a paper, but then you'll have people who take a piece out of the paper and they don't understand it, and then they'll put it up in lights and say, "This is it."
Right.
So it's the interpretation, it's all different opinions, and it's the logistics of the studies. It it's a real minefield. Um, so that's why I really like to understand a lot about the patient before I actually start hormone therapy, because I want to give them an idea, you're a low risk, you should take it. There are women who've got quite a severe metabolic syndrome, overweight, blood pressure, their triglycerides in the blood are high. Don't care so much about the cholesterol, but it's the triglycerides. and their insulin's a little bit up, and their CRP or their inflammation markers are a little bit up, and it's just so I think we need to just work on you and not use hormone therapy because their estrone levels are quite high, which is a form of estrogen coming from the fat cells. And the last thing I want to do is give them more estrogen and perhaps increase their risk of a stroke, which I'm not isn't borne out in the literature too much, but they're the ones that really will suffer from the cardiovascular side effects rather than the benefits.
So
Yeah,
people
so
that
you have
come
to
to
know your
you,
patient well.
you really educate them as well. I mean, that's like
Yeah,
part of, yeah,
yeah,
you have to educate them first and then prescribe what they personally need. Yeah,
yeah, that's right. That's right.
interesting. Well, I think that anyone can benefit from reading your book and
Mm.
to keep them in their library to refer to because it's a major education. Very, very important. Any special things that you feel you have kind of underlined in your book that might not be in other places?
I mean, no one's made it simple for the scientific sort of classification of pre, peri, and menopause. So I've created the zones which are based on the scientific straw criteria, stages of reproductive aging criteria. And I was at one or both workshops, I can't remember, that created the criteria. So I did my own research and it's been published like 2003 to 2007, but my data got presented at the North American Menopause Society just in October.
Hmm.
So
Congratulations.
Nina sent me a snapshot of my slide, my data, in one of the talks. And I'm finding it's going to be more, they're understanding it more. The research that I did like years ago,
Wow.
they're understanding it more. And the reason why it hasn't been repeated is that I actually took blood out of every single one of my 77 patients 3 times a week for their entire menstrual cycle, which sometimes was very long. And so this logistically is not easy to do. I
Right.
did everything because I was a specialist doctor already and I had sort of free range to do blood pressures. I did ultrasounds of their ovaries and I did blood tests. And most studies are, it's hard to find studies that are not on a drug. Okay. Intervention drugs, sorry, intervention trials on drugs are the mainstay of research. There's very little research money in anything that's just looking at what actually happens in the body. And that's one reason why I did this study was there was these intervention studies given to premenopause and perimenopause women. But I was saying we don't even know what's going on in the first place. So we don't know whether it's a normal change or it's a change because of the intervention.
Right.
So that was one reason why I did all the study. And it's not been sort of repeated, but yet the data is still being sort of used as an example of why you see excess bleeding
Hmm.
in midlife and perimenopause, and why you see the short cycles in midlife and perimenopause, and why you can capture really high levels of estrogen. I've explained all that,
Hmm.
in addition to some of the ovary data from Canada,
Hmm.
which was done around about the same time. So yeah, just last month, here was my slide, my data from my original study shown in a talk at NAMS, the North American Menopause Society. So yeah, I've written a chapter or two on the physiology of the menopause transition. So I don't think there's too many authors out there that have done that level of research, but we're also practicing functional medicine
Right.
because
Right.
it's hard to do both. And
Right.
I did leave the research world because there was no money in further basic research. It was all pharmaceutical driven, and all the money was coming from a pharmaceutical company. So I said to my supervisor, so that means that's it for my primary research, and I'm going to have to do their studies.
Right.
And he quietly nodded his head and looked down and, he admitted it. So I didn't take on the chair at the University of Sydney because of that, because
Right.
I couldn't stand just doing drug research and then being stuck in red tape for the rest of my career.
So you've you've really given the answer to my first query, which is difficult to find, you know, research enough on these situations because whatever
Oh,
research
right,
there is has to do with drugs, pharmaceutical industry. Yeah. Uh,
right. Yeah.
is so what can you simply maybe explain what would be the cause of a great deal of bleeding in premenopausal gestation?
It's the first chapter of the book where, with reproductive aging, over 35, over 40, the little tiny ovarian follicles in your ovaries, we have a reserve of
Right,
not millions, but hundreds of thousands of them at birth, and they gradually deplete
right,
through the process of natural attrition, atresia, or ovulation. Now, you lose about 30 to 40 ovarian follicles every time you have a menstrual cycle. So
right.
that as well. But they do undergo atresia in the ovary. We don't know why. But by the time average losing 40, you start to really get down to the hundreds or thousands left. Now, when you get to hundreds or just thousands left, there's a hormone in the ovary that starts to go down. And it's that reduction in that hormone produced in the ovary called inhibin B. A reduction in that triggers something in the brain, in the
Uh-huh.
pituitary and the hypothalamus. And that reduction in inhibin B, because you're losing ovarian follicles, revs up the production of follicle stimulating hormone. So you get more FSH every cycle that you go through. So this increase in FSH whacks each of your ovarian follicles and probably causes an increase in the estrogen output from each follicle. Mm.
And that causes
So
the
even
excess bleed.
Yeah, so even while you're having regular cycles, this can happen.
Mm.
About a third of women you'll see this, but other people won't notice a difference in flow. Other women will find that they have a full-on menstrual bleed twice a month. Very
Mhm.
common. Because the higher the FSH, the more likely you'll pick up ovarian follicles even between menstrual periods. So
Yeah,
you get what we call a loop cycle, which is what is in the literature.
yeah,
So luteal out of phase cycle.
yeah.
And it's
Interesting because yeah,
because of the coordination between your ovary and the brain. The ovaries are starting to run out, and the brain goes, "Oh, we better kick on the ovarian follicles through FSH,
right.
follicle stimulating hormone from the pituitary."
Right. Well,
So
that's
it's
why
that
I
sort
was
of feedback.
saying that that's why my hemoglobin was 5, and my doctor was saying you need to go and get this out because you're going to die. Because I remember I lived in New York City and I was going up the stairs and I could hear my heartbeat in my ear, you know?
Trying to get the blood through to you.
Yeah, 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 yeah. It was crazy. And my nails had like all like buckle. It was the weirdest thing. But I would have my menstrual cycle out of the 28 days, it was go for 27. It was horrendous. But
Yeah,
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 so and I don't know. I mean, is there a way of like balancing it out, or is there no way? It's just what
yeah. So
there is.
as I said, the kind of I don't use progesterone as much to balance out bleeding
Right.
because it's difficult. Yeah, you can give up to 400 instead of the usual 100, 150 milligrams of progesterone. It may have an effect on the bleeding, but that bleeding's going to happen. Now, the progestins are quite potent, and using progestins at in sort of medium to high dose, that is more effective on, seems to be more effective on the bleeding.
Uh-huh.
So you can try the high dose progesterone, but you've got to time it so that you sort of go on it full time, so you gradually reduce the bleeding. But fibroids are very difficult because
Yeah.
the effect of fibroids on bleeding is not amenable to progesterone or progestin. It just doesn't seem to affect it. So the
Right.
bleeding is, and the running down of the ovary and the FSH, that was all very difficult to turn off, except if you obliterate, you use oral contraceptive pill or you use some other drugs to just shut
Yeah.
this down, which is full of side effects.
Yeah.
So my focus on people with fibroids or endometriosis, a lot to do with stress and irritable bowel syndrome, is to encourage estrogen elimination in the body and just balancing out everything else. And you've got to be pretty pristine in your diet.
Right.
Um, no sugar. And despite what the specialist guts people say, I take people off gluten or introduce very clean gluten or other products that don't have a high amount of gluten and alcohol, these sorts of things. And not eating between meals, really concentrating on gut health and then the bile flow and making sure that your bowels are flowing really well. Hidden constipation is a big risk for just getting clogged up with your own hormones. And
Yeah.
some people have no idea that they're constipated. So that's why I take a picture, just a plain old x-ray of everyone's tummy to see how much they've got left in a normal day.
Yeah.
And that can tell me a lot.
It's actually really interesting because in the Eastern world, from times of many times ago, the first thing that as soon as there was anything wrong with you, the first thing that they would check was, how is your bowel movement? And I am astonished that, especially in the US, that people think it's normal to go like 5 or 6 days or 7 days without having a bowel movement. And the crazy stuff
And
is,
it's not a feature of like clinical medicine. It's
yeah,
not,
it's
you
crazy.
might,
It's
it's
like,
only, and it's crazy, yeah.
it's
Yeah, they
how
don't take much notice of constipation.
everything is connected to how clean your intestines are. And
If you're a person that thinks you only get a constipation, that's a little bit, and you got a hard stool, whatever, worth doing an x-ray, because there's plenty of people I see a
yeah,
huge backup on who have a daily bowel action. Like, what? How could I be constipated? Because you've built up this ability to just hold all this poo in your body. Imagine the toxic load that your body's trying to take care of.
yeah,
So if you keep that out and off your plate as a detoxification, you've only got all your own hormones and the environment coming in at the time. You haven't got all this stuff stuck in your bowel,
yeah.
because it does leak in. It's not as if it's a completely barrier,
Well, I mean, you
100%
have so many
barrier.
people who have leaky gut, who have what's the other one that
And it's IBS or inflammatory,
yeah,
irritable
yeah,
bowel
yeah, yeah,
syndrome.
yeah,
Oh yeah.
yeah, yeah. Huge,
And
huge.
bloating's a lot of part of the women's symptoms, feeling like they're pregnant, and it's a very common symptom, swelling,
Yeah,
all that sort of stuff.
yeah,
Yeah, it's really important to have the bowel working and have a good diet where you don't eat between meals and sugar's out for a lot of people, a
yeah,
bit for some people.
yeah.
Yeah. And
So
yeah, it's very
important.
personalized approach. And if you
Yeah,
do learn from books like mine, you can tune into your own body and say, well, I am that sort of person. So you can go with a list to your own doctor and introduce the book to your own doctor.
yeah. That would be great. I don't know how many people would accept it though, but I mean, how many doctors would accept it, but maybe, yeah. Well, this has been very,
Research.
very informative, and
Yeah.
I'm sure you're going to get many people interested in buying and sharing your book with their friends and family. And as I said, I have two clients who are functional medicine, and uh, they're both very interested in checking it out. So that's great. I will, of course, be sharing your link. And you have a website as well, correct?
Yeah,
Yeah, yeah.
really the
Do you
most
see?
beautiful version on my website, and we
Okay.
are shipping to the US. So
Okay.
I
Fab.
just thought I might eventually sort of make my website the main place because it is such a nicer version than the Amazon crew who
Oh,
do
okay.
their own printing.
Right, 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 right.
It's okay. It's got all the, the color and everything, but
Right.
it doesn't have the dust jacket and it doesn't, open as nicely. And yeah, we're pretty proud of that one that you can get off my website. But the ebook, I will be coming out with a simple ebook that explains the zones as well, because I
Uh-huh.
think the zones are important for me to establish. Don't I don't want people to, or other authors to take it and change it and do all that sort of thing. So I
Right,
wanted to have it as a separate ebook as explaining the scientific reproductive aging
right.
stages and how you, as women, everyday women, use that
Well,
in
you
your
have a
zones.
copyright too, right?
I do, but I don't know whether that protects very
I
well.
think it does. I mean, as you know, I have a book that I published. It was all my grandmother's recipes. I don't remember. There are like three or four steps that you have to do to protect the integrity of your book so that nobody copies.
Yeah, oh, we
So
do that, but I think sometimes it can be taken out of context. So I thought I'd just
yeah,
isolate that as a as an
yeah,
ebook just for
right.
people so that it's actually out there,
Hmm.
and it's really easy to tell whether someone's copied it and then twisted it.
So let me ask you
Yeah.
another question before we say adios. Do you also like have clients can like someone Zoom connect with you, have an appointment with you on Zoom from the US or France or Italy?
Yeah, sure. And I've seen one of my sister's distant relatives uh, from Michigan, and she will take her letter to her GP, and they can do what I suggest.
Right.
Um, and then I
Prescribe the
can
blood
follow up.
test.
So
Yeah.
I won't be ordering all the tests, but I
Right, right,
can
right. Yeah.
uh, suggest the tests for
Right,
their primary physician to
right.
do. Yeah, and I think
There is a
if
website, just so you know, maybe you do know, but there is a website where I'll send you the link where you can go and choose the different tests. They have all different, and you pay for it, and
yeah,
then they send it. Yeah,
yeah.
yeah.
So you can do it either privately like that, but I haven't done that yet. I'm aware of it though because of
Okay,
this work. But I mean, I think most family doctors will recognize that, the work is very legit and that I
right.
did my own research.
Sure.
So I mean, I think most who are delving into women's health would probably look at it and go, it's probably worth reading, so
Good.
that they can work together with their GP.
Right,
And of course, there are some sticky situations with what to use in hormones. And a lot of GPs won't want to use the progesterone cream because it's not FDA approved, because it's difficult to make any money off that kind of product for a pharmaceutical industry. And
right,
then therefore you don't get it.
right, 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 right. Um, any last golden nuggets that you would like to share?
I guess that you know, functional medicine really does allow women to be in control. And understanding your body
Right,
really does allow women to be in control more. And I think it's more important than ever to have fruitful two-way discussions with your healthcare provider. And that isn't as possible if you're not well informed.
right,
And the old school healthcare provider won't want patients to be informed, will they?
right.
They just want you to follow instructions and take what they suggest because
Right.
there's all these boards and all these, specialists and um, experts that have said you must take this. It's
Mhm.
those days are gone, and it's a awful system. I
Mhm.
think America, the way that the pharmaceutical industry has done so many awful things to
Yeah.
patients. The lack of trust is warranted. I tell you, it is. Of course, it is. And so, being more informed about the body and educating yourself is even more important for people who are interested. I think there's always going to be people who just say, "No, I'll just do as I'm told."
Right.
That's not you and me.
No, always have lots of questions.
Yeah,
Yeah,
yeah.
that's the way to go. Well, Georgia, it was lovely to have you, and let me know when you publish your ebook. I would love to speak with you further. And as I mentioned, I'm sure lots of people would be interested. Thanks again. Great to see you. Do come and see us in Florida at some point. I know you travel all over. Anyway,
Yeah.
thanks so much. Have a lovely rest of your day, and I'll say good night and good morning to you.
Thanks for having me, Feroza.
Absolutely. And for all our viewers, thank you so much for watching. I know I felt that this would be a very, very important interview to illuminate many, many women out there. And so please do share with friends, family. And if you have any questions for Georgia, please put it in the comment section. Thanks again. You can see the shorts on Instagram and watch the whole interview on YouTube and Rumble. Thanks again. Thank you, Georgia, for joining us. Have a wonderful, wonderful evening. Bye bye.